go back and
Okay. Okay. Well, we got that. We'll hold our questions till the end, and we'll have people either write them in the chat or write them down, and that at the end we will then review all the questions. So again, thank you, Dr. Curry. This is the Association for the Chronically Mentally Ill. It's a group of board members and now stakeholders that care very deeply about people with chronic mental illness, serious mental illness like schizophrenia, bipolar psychosis, major depression, the big guys, the big ones. And it's our whole purpose for our board. We're all volunteers, many family members. We have a couple of attorneys and a couple other business folks on the board, and we work at passing legislation, which in the past years we've been pretty successful. We have our board president who's on, Josh Moselle, and several other board members. But with that, let me introduce you. The first Tuesday of the month, we have a speaker, a guest speaker, that can talk about different topics that would be of interest. And today we're pleased to have Dr. Stephen Curry of Banner discussing genetic testing and medications. Dr. Curry grew up in the Midwest, graduated from Bradley University with a degree in molecular biology, and then from Southern Illinois University School of Medicine. He is trained and board certified in medical toxicology, which is a specialty concerned with pharmacology, also adverse drug effects, and intentional and accidental poisonings. Dr. Curry also oversees a pharmacologic or pharmacogenetic service at Banner University Medical Center in Phoenix, which is testing is performed on selected patients to help choose the best drug and dose for individual patients. He also teaches pharmacology to medical students at 2 medical schools and is a faculty member in the Department of Medical Toxicology at Banner University Medical Center in Phoenix. He and his group of physicians admit and care for toxicology patients at Banner University Medical Center, Phoenix, and Phoenix Children's Hospital. So, wow, we are so thrilled to have you here. And with that, I'll turn it over to you.
well, thank you. I'm going to attempt to provide in an extremely simplified explanation what pharmacogenetics is all about. And pharmacogenetics is commonly used by many psychiatrists for the treatment of various patients, but is also used extensively throughout medicine, having nothing to do with psychiatry. And because patients with various mental illnesses get all the other diseases that everyone else gets, we all are commonly on medications in our lifetimes that can be influenced by our genetics, what we've inherited from our patients. And that general category of research or specialization is known as pharmacogenetics or pharmacogenomics. Now, if we take a medication,
Garage entry door open.
if we take a medication as shown up here in the top here, this
Yes.
medication,
I will mute who's ever speaking if I can find them.
It's Barbara Honenberg.
Yeah.
are,
Okay, I muted her.
okay.
Sorry about that.
Oh, it's all right. When you have this many people on a meeting, it's hard to not have someone who's unmuted. If we take a medication, we find that this medication, after it gets into our body, can have its desired action. It binds to some sort of receptor, for example, in our brain, and does what we would like it to. This medication sometimes has side effects, which we generally refer to as toxicity or adverse effects or side effects. But in some instances, the medication is actually inactive. That is, the medication we inject or the medication we take by a pill in and of itself cannot produce an action, and it has to go to the liver and first be what we say metabolized or activated and changed in chemical structure to an active form, which then produces a desired action. And this is usually the case when a particular medication would not be absorbed orally, for example. And we have to change its chemical structure in order to get it into the body after taking it as a pill. And then we allow it in the liver to be converted to that active form that never would have been absorbed orally, but now it's already in our body. We trick the body into forming this drug, and then it goes on and has its desired action. So one consequence then of metabolism, that means to change its chemical structure, of metabolism in the liver is to take a drug that's inactive and make it active. On the other hand, most medications we take are active, and after they get in our body, we do have to get rid of them. And most of the time, we get rid of them by sending them to the liver, and the liver physically changes the chemical structure of it. We say the liver metabolizes that drug and causes it to go into various breakdown products, which then we excrete in our urine or in our stool. If we take 100 people of identical sex, of identical age, who have the same weight, who have the same disease and the same severity of disease, and we give them all the exact same dose of medication to treat that disease, we'll find that the majority of patients are somewhere in the center of this bell-shaped curve, and they have some sort of expected response, some more than the others. We have at one end of the curve, though, those who have a suboptimal response, and then we have a few who don't respond at all. And at the other end of the curve, we have those who have exaggerated responses, which we may call side effects. And as an example, I may give a medicine to slow someone's heart rate down, and a person who has an exaggerated response or a side effect may get a heart rate that's way too slow, and they begin to faint. And then we have a few clear out here who suffer profound toxicity and might even die because of a response to this medication. And we don't understand all the reasons for this variation in response, but we know that at least some of them are due to variations in the genes that result in the metabolism of these different drugs. Our liver, which is shown here outlined in this sort of red-orange cover in the color in this photo over here on the left. Our liver is where most of these drugs are either activated or inactivated by metabolism. And we have all sorts of different enzymes. Enzymes are proteins that are coded for by our genetic code in our what's called DNA. And I've just put here some examples of drug metabolizing enzymes here. I'm not going to bore you with names right now. And you can see there are all sorts of different categories, but I'm going to give you one example right off the bat in this light blue here. This is known as CYP3A4, also known as cytochrome P450-3A4. And it is an enzyme in the liver that's responsible for metabolizing about 55% of all drugs. As another example, in the yellow here in our liver is an enzyme called cytochrome P450-2D6, or what we call CYP2D6. And it's responsible for metabolizing about 25% of all drugs. And some drugs they can be metabolized by more than one of these numerous different enzymes involved in drug metabolism. If we take a single cell, and for example, in an adult liver, we have about 240 billion cells. A cell has a nucleus in the middle, and then it has a membrane around it that we call the cell membrane or the plasma membrane. And we have 240 billion of these on average in an adult liver. If we look inside the nucleus of this cell, and we would zoom in on a microscope, we could come down, and in the nucleus, we would see what are called chromosomes. And our DNA is broken up, that is our genetic code, is broken up into different chromosomes. And if we would just take one of these chromosomes, and then we would zoom in on it, we would find this, what we call a double helix or double-stranded DNA that wraps around itself. And then if we could even zoom in more, even on a single DNA molecule, we would find that there's cross-linking between these two strands. And we aren't going to go into biochemistry here, but I'll just say that the strands are composed of what are called nucleobases. that cross-link with each other. And these bases, that is the order in which they appear in the strand, is the genetic code that our body reads to make these different enzymes that are responsible for metabolizing drugs, either inactivating them or activating them. Now, we each have 23 pairs of chromosomes. One pair are what are called our sex chromosomes. If we are genetically born as a female, as a genetic female, we have 2 X chromosomes, one from our mother and one from our father. If we're born as a genetic male, we have an X chromosome from our mother, and we would have a Y chromosome from our father. But the rest of the chromosomes, the remaining 22 pairs, are what are known as autosomal chromosomes. And it's on these autosomal chromosomes where the genes lie that are responsible for making all these different enzymes shown in this little colorful diagram down on the bottom right. And for example, this would be a good exam question if I were being examined for board certification, but I think P450-2D6 actually sits on chromosome 22, if I recall. And what this means then is that if I look at chromosome 22, I actually have 2 copies of this P450-2D6 gene. I got 1 chromosome and 1 copy of the gene from my mother, and I got the other chromosome and the other copy of the gene from my father. So for all these different enzymes for drug metabolism, I've got 2 copies on each what we call allele, or each chromosome from our parent, 1 from our mother and 1 from our father. Now, if I take the top right here, we're going to take a chromosome here. I just wanted you to understand, and this is something that continues to be truly amazing to me, is that these not only are just coiled DNA, but they are what we say are supercoiled. And if we took a chromosome and we could zoom in on it and we could unwrap it, we would find that we would be unwrapping a long strand that in and itself is coiled. And if we unwrap that coiling, we find that it consists of further coiling inside. And if we unwrap that coiling, we find long strands of DNA that are wrapped around proteins that we call histones. And then finally, if we can uncoil that, we finally can come down to the double-stranded DNA, or what we call the double helix, with these nucleobases here shown in different colors. And these nucleobases, that is the order in which they appear, represent the genetic code that our body reads in order to make different enzymes and proteins. This is an electron microscopic view of inside of a single cell, inside of a nucleus, and this is uncoiled DNA. And so when a cell is at rest and it's working and it's making enzymes, the DNA uncoils so that these individual strands can be exposed and can actually be read by the machinery responsible for making these different enzymes. Now, in our bodies, not in our livers, but in our entire bodies, we have about 30 trillion cells, and each cell contains about 6.5 feet of DNA if we could uncoil it completely. And therefore, each person listening today has about 93 million miles of DNA in their body, which is enough to stretch from the earth to the sun. That's how much DNA all of us have in us that contains the genetic code and is responsible for keeping us alive. Because we get 1 copy of a gene from our mother and another copy from our father, it depends on what or whether mutations have occurred or changes have occurred in those genes that may explain why we see variable responses. And let me expand on that a second. It's very common in that genetic code that we show back here in different colors to have a change. And when those changes are commonly found in the population, that is, maybe this one I'm showing with my pointer here that shows yellow going to blue. If instead that changes to red to green, so I've got 2 red greens in an order, and that occurs more than about 1% of the time in the general population, then we say that that genetic variation that normally occurs in the population is what we say is polymorphic. So a polymorphic variation is something that occurs relatively frequently, and you can set the percent at whatever you want, but generally we talk about genes that occur 1% of the time or more frequently in the population. And it turns out that sometimes those variations, when they occur, result in a gene that doesn't work at all, or maybe a gene that works super well, just the opposite. And we take patients then and we look at their genetic code and we divide them into different groups. If they have inherited from each parent a gene that works normally, we say that that person is or another thing we will say, another word we use to mean the same thing is an extensive metabolizer. These two words are synonymous. If we inherit from each parent a gene that does not work because of a genetic variation in that gene, and therefore we don't have any enzyme activity or perhaps very little of activity, then we say a person is a poor metabolizer. If they get one good gene from one parent and then an inactive gene from another, we call them an intermediate. And then sometimes we have inherited genes that have increased activity. They work super well, a lot more than just a normal gene would work. And we call those patients either rapid or sometimes ultra rapid metabolizers. And collectively, what I'm showing you on the right here then is what we say the phenotype is, how they behave, while the genetic code tells us what their genotype is. We do genetic testing and look at the code, and we understand what these different genetic variations do to gene function, and then we are able to predict what we believe the phenotype will be. Now, there are numerous companies that produce screens or provide blood tests or tests that you can do from scraping inside the mouth, as I'll show you in a second, and test for different genes. I'm just showing here as an example a panel that we built with Sonora Quest Laboratories here in town. And the panel that we use at Banner University Medical Center looks at 22 different genes. And then among those 22 genes, we look for generally about 120 or so genetic variations. And so, for example, P450-2D6 here, here's CYP2D6, I'm circling. That's one of the 22 genes. And in our test, we look for 29 genetic variations that occur in the population that may increase the activity or decrease the activity and produce various responses to different medications. The test can be run on blood that can be obtained by venipuncture. And this is what we prefer to do, especially in the hospital, because we always get plenty of DNA if we can get a tube of blood. But we can also just take tests, or we can just take swabs and just scrape the inside of the mouth, sort of like many of the mail-in DNA tests you can do for genealogy. And we can take samples from here, and the great majority of the time, these work adequately as well, but they aren't quite as reliable to get enough sample as a blood test is. Now, I think the easiest way to understand how this all may work clinically is to give you an example of a patient. So here's a woman who has high blood pressure, and she was 51 years old, and she was put on a very commonly used blood pressure medicine called losartan. And here's a picture of a pill over here. And losartan can be quite effective at lowering blood pressure. And when she was put on it, nothing happened. Her blood pressure did not fall. And so if we look at this bell-shaped curve here in the center, we would plot her way over on the left as a non-responder. Now, we don't know right now why she didn't respond, but it certainly didn't do anything for her. So her physician then said, well, we're going to switch you to a medicine that works by a completely different way. We're going to switch you to what's called a beta blocker, and we're going to switch you to metoprolol. And Lopressor is one of the many brand names of generic metoprolol. Metoprolol can lower your blood pressure and also can lower your heart rate. Well, she took metoprolol for 4 days and then presented to the hospital after losing consciousness. She was found to have extraordinarily low blood pressure, and her heartbeat was only at 32 beats a minute. And therefore, for metoprolol, we would plot her way over on the right side. She responded, she was extraordinarily sensitive to this drug and actually developed toxicity. And she spent 4 days in the hospital, had a cardiac catheterization, thousands of dollars were spent, and then she was finally able to be discharged. So we were asked to evaluate this woman to try to understand what was going on. And here's losartan, the first medicine shown in the red square here that she had failed to respond to. It is an inactive drug. It has to go through an enzyme that we call CYP2C9 to form an active drug in the body, and this is what lowers the blood pressure. And when we looked at her genetic test, her pharmacogenetic test for 2C9, we find that she inherited one gene that we call STAR1 for being normal from one parent, and she inherited another gene that we named STAR3 that's inactive from another parent, which makes her an intermediate metabolizer. She was very poor at converting losartan to the active drug and therefore did not really respond well to that drug. So then we have to wonder, why was she so sensitive to metoprolol? Well, here's metoprolol in the red square. It is an active drug, and it is normally broken down and metabolized by that enzyme called CYP2D6. And it goes to inactive metabolites. And if a person did not have CYP2D6, each day I keep giving her a dose of metoprolol, and she's not getting rid of the drug overnight. And it keeps building up to higher and higher and higher blood levels until finally she develops toxicity. And if we look up here at her CYP2D6 results, she has inherited 2 alleles, one named STAR4 and the other named STAR5. These are 2 different genes. She's inherited them from each parent, that is a STAR4 from one, a STAR5 from the other, and she is a poor metabolizer. She has no significant 2D6 activity. And if we look at the white or the European ancestry population in the United States, about 8% of us are what we would call poor metabolizers for 2D6 and have a poor ability to metabolize drugs by that route. Now, if we would have known this before she was started on medication, we would have chosen neither one of these drugs, or we would have chosen a much smaller dose of metoprolol to begin with, and then build up very slowly and carefully in the dose until we saw the appropriate response. As another example of how this works, many women and occasionally men, because men do get breast cancer as well at a much lower rate, are placed on tamoxifen. And tamoxifen is what we call an estrogen antagonist or an estrogen blocker. Some breast cancers, if they have estrogen receptors, respond and grow more in response to estrogen, and we can block those receptors with this drug tamoxifen. Well, tamoxifen is an inactive drug. It doesn't do anything by itself, and it has to go by a couple different steps here. It has to go through CYP2D6 to become an active drug called endoxifen. And therefore, patients who are born with poor 2D6 activity get much, much lower endoxifen levels for a given tamoxifen dose than patients who have normal 2D6 activity. And they may not respond as well to tamoxifen for the treatment of breast cancer or for the prevention of breast cancer, which this drug can also be used for. When companies put out the results of pharmacogenetic tests, they can be presented in all sorts of different various profiles. Some of them are just brief 1 or 2, 3 sheets of paper. Others, our reports sometimes are up to 40 pages long and detailed. And what I want you to recognize is that the reports that many, but not all of these companies put out, but all of them should put out, are actually written for medical staff and for physicians. So they aren't meant for you necessarily as a non-medicine person to understand although you may gather information from it. The first page or two usually lists all the genes that were tested, and it's shown here. This is the first couple pages of an example of a report we used to generate. And then here in the third column is whether you're, for example, a normal metabolizer, an intermediate, or, for example, a poor metabolizer. And then here we just have a brief statement, perhaps, just describing what the implications might be of this genetic variant. Then if we continue through the report, we take all sorts of different categories of drugs that may be affected by pharmacogenetic results. For example, analgesics are pain relievers. And we have anesthetics, anti-infective agents, such as antibiotics or antiviral agents. We have different blood pressure medicines that are cardiovascular, for example, or statins, or what we call antiarrhythmics. We have all these different classes, and we break them into different classes. And then in our current report, we put them into two different columns. If it has green, we say the pharmacogenetic result for this patient does not change the way we would dose the drug. That doesn't mean the patient may have other reasons to be sensitive or insensitive to the drug, but there's no pharmacogenetic reason that would mean that we should consider changing how we use this drug. Or it can be over here in the orange column. And here it says there is a genomic effect. That is, maybe the dose is going to be on average lower in this patient. If we're going to see a result, maybe on average, these patients are going to require higher doses. Maybe these patients should not even be on this drug, and an alternative drug should be considered because there may not be a response at all. As an example, then, as we go through the report, we can look at an antidepressant called amitriptyline. And as we continue through the report, we see for this patient, it said likely decreased efficacy. That is, it's not going to work as well. Likely, we don't know for sure. We just are doing this on a statistical basis. And we say the evidence for this likelihood is strong, and it's because of this genetic result in them. And I'll tell you right now that when you see, this is what a nerd I am, but when you see CYP2C19 star 17 / star 17, that means they inherited a star 17 from one parent and a star 17 from the other. And both of these are fast metabolizing genes, which makes them an ultra rapid metabolizer. And the reason amitriptyline may not work in this patient is because they're just going to get rid of it so fast. You can dose it and they just metabolize it so quickly, it's unlikely you're going to get the dose high enough. And here's citalopram in this same patient, also metabolized by 2C19. Points out they're an ultra rapid metabolizer, and it may not respond, and recommends considering an alternative drug or giving a higher dose. It's harder to use sometimes really high doses of amitriptyline because of side effects. You're more likely to get away with that with a drug like, for example, citalopram. And then for the physicians, as you continue through the report, we even provide additional information. For amitriptyline, we give them a discussion as to exactly what's going on and why this variant would produce this particular result, and make a specific recommendation, and then even provide scientific references to back up this general observation that we've provided for a patient with this particular phenotype. Now, how often are these genetic variations found? Well, if you look at those 22 genes, for example, that we test for, 98% of us will carry at least one high risk. By high risk, I mean something that would be impactful and may cause us to choose a different drug or to adjust the dose on a drug for medications that are commonly used during our lifetime. Now, some of us aren't on any medications, even when we're 75 or 80 years old. And of course, it wouldn't matter what our pharmacogenetic results were, they would not be impacting us. But others of us, even at relatively young ages, may be on multiple medications that can be impacted by these. If we look at the population in the United States and say what percent don't respond or respond inadequately to at least our initial therapy with the drug, we see that for antidepressants, it's about 38%. Now, That's not all pharmacogenetics, but some of that is pharmacogenetics. And as many of you know, it may take trials with multiple different drugs and different doses or combinations to find something that hopefully will finally work, while perhaps, and that may take several weeks or several months or sometimes even years before that can be discovered. And some of those are explained by variations in pharmacogenetics. This is an example of psychiatric drugs I put together for which we have guidelines, or we know that pharmacogenetic variations that we test for may have an influence. And I've listed some antidepressants here, some antipsychotics, some stimulants, and some miscellaneous drugs used in the treatment of psychiatric disease. I don't mean for this to be 100% inclusive, but this includes the majority of the ones that we encounter. Now, if you're a physician practicing in a hospital and you're getting paged all day long and you're asked to write a prescription, this patient needs this medicine, this patient's deteriorating, I need to start this or whatever, you can't stop each moment for each patient and search the medical record and try to find their pharmacogenetic results, read through them all, and even know which results are pertinent for that particular drug. That's just too much information unless it's something you specialize in. Therefore, what we do at Banner Health is we have an electronic medical record. This is the computer the physician gets into that contains all lab results, for example, but also is how the physician orders medications. And when we have the results that we order from within the medical record from SQL downloaded into Banner Health, they are found in the electronic medical record, and if a physician searches for them, they can easily see them. But what's more important is that whenever a provider, whether it be a physician, a nurse practitioner, or whatever, orders a medication, that name of that medication is immediately analyzed by the computer. And the computer says, do I need to worry about pharmacogenetic results if this patient happens to have some? And if the answer is no, then no alert is provided to the provider. But if there are pharmacogenetic results available and they pertain to this particular medication, then the computer says, well, yes, I do need to be concerned, and it looks for the results. And if the results are unremarkable and do not pertain to this particular drug in this particular patient, then the provider again gets no alert whatsoever. But if the pharmacogenetic results are available and suggest that an alternative drug should be used, or perhaps a different dose may be required, then at the time that drug is being ordered, an alert is provided on the screen to the provider, informing them and cautioning them and telling them where they can go and find the pharmacogenetic results if they want to learn more about it. And for example, here's an order being entered for citalopram or for escitalopram, commonly used antidepressant, sometimes used for other purposes as well. The computer says, gee, I know that for this drug, I need to worry about CYP2C19. Are the results on file? Nope. Okay, the order just goes right through. If the results are on file and the patient is a normal metabolizer or what we call an intermediate metabolizer, it goes on through. We don't display any statements because those results would be irrelevant for that patient. But if they're an ultra rapid metabolizer and it may not work or they need a higher dose, they're going to get one warning statement. If they're a poor metabolizer and they can't get rid of the drug and may require a lower dose, then they're going to get a different statement. Now, as we finally begin to finish up here, one may ask, well, which patients are most likely to benefit from pharmacogenetic testing? And so, for example, if you were assigned the task of to begin implementing testing for pharmacogenetics, drawing a blood test or scraping the inside of the mouth with a little swab in patients to get their results on the record because of the likelihood that they will be on a medication that may be influenced by those test results someday, which patients would you choose to test first? And what we did then is we took a patient of about 1,000 patients in each group here, and we just picked various groups within the healthcare system, and we said, what percent of those patients at this particular moment, not in their lifetime, just right now are taking medicines for which there would be recommended or strongly recommended actions if they knew what the pharmacogenetic results were and those results were abnormal. And because of the interest of the group here, I wanted you to see that for adult psychiatric inpatients, it's about 73% or so. And if we look at adult psychiatric outpatients, it's right around 29% or so on average. That's what we happen to observe. If we look at psychiatric outpatients less than age 18, it's on the order of 10 or 12%. But many of those patients may be in psychiatric clinic for attention deficit disorders rather than for more severe psychiatric illnesses. So, which patients should be tested? Well, what do the studies show? Well, they've shown that if you take patients and you receive pharmacogenetic guided treatment, that is, you're starting to treat them initially. You don't know what their response is going to be to medications, and they're coming in for depression. If you test them right off the bat and use the results of those tests to guide your therapy and your doses, that you're about 41% more likely to respond favorably as compared to someone who does not get standard therapy. Now, if you are not tested, you may eventually respond. It just may take a while for you to figure out which drug you should be on and at which dose. Most studies also, not all, but most studies demonstrate that testing in psychiatric patients, mainly for depression, because they haven't been examined in a lot of studies with regard to antipsychotics, mainly for depression, is cost-effective and cost-saving strategy. And some studies report 58% reduction in hospitalizations. And again, this is most common when used in initial therapy. 40% reduction in emergency department visits for adverse effects or failure to respond, and about a 13% reduction in clinic visits. Well, with that background, some psychiatrists, for all new patients, go ahead and test their patients. They just take a swab in the office or they order a test, and they just want the results in the record. And unless you have a liver transplantation in your lifetime, you just get tested once, and those results stay with you forever. Your genetic code responsible for metabolizing drugs will not be changing. And there's a couple academic medical centers in town, in fact, who routinely test all new patients because they say, you're going to be with us for several years, potentially. We may be using various medications. We want to know in advance what your pharmacogenetic profile is, because it'll really help us with future pharmacotherapy. Other psychiatrists say, it's a hassle to test. It costs some money to test. Most of my patients will respond to initial therapy okay. And I'm only going to test those patients who are failing to respond as I would expect them to figure out what the problem might be. Or other psychiatrists will say, I'm only going to test patients. They may be responding to therapy, but they're having lots of side effects. Maybe their drug level's too high, and I'm going to see if I can find a pharmacogenetic reason for that. I want to state right now that there is no official statement by a professional organization, for example, of psychiatrists, and there's no official standard of care that says patients should or should not be tested. But as I've observed pharmacogenetic testing in the psychiatric community over the last 10 or 15 years, it's increasing more and more and more. And many of you probably have dealt with psychiatrists or psychiatric services, and maybe you've had some of your relatives or friends even undergo testing to be used in therapy. But I just wanted you to understand that there is no standard of care, but this is generally the basis on which physicians decide who needs to be tested. We do want to be sure that joint decision-making is occurring, and that the patient and the psychiatrist should decide together that testing would be indicated and agree to it. And that if a patient or a family member would ever get results of the test, perhaps before the psychiatrist does or without seeing the psychiatrist, that you should never change a dose or a medication based on the results of the test without talking to the psychiatrist. Just because the test says consider an alternative drug does not mean that an alternative drug must be used. In fact, if they're responding really well to that drug, they may not need to change anything. So just be aware that the test doesn't necessarily say a drug can't be used. It just suggests what's going to, on average, work out better. For patients who are already on medications that are working well, pharmacogenetic testing at that moment probably is not going to change anything. And I also am asked how much testing costs. It ranges incredibly depending how many genes you want to screen for and what companies offer the testing. And on it, I've seen them range anywhere from about $150 to about $3,000 or so. And some of them can be quite a bit more extensive even than the panel that we do at our center. So that's all I have today. If anyone has any questions, I'll be glad to take them. And maybe, Laura, you want to sort of do the MC work here.
Okay. First, I wanted to say incredibly interesting and a fascinating topic. I've seen some of this at other banner. I've seen some of their genetic testing, and to me, it seems like we should always be testing, especially if you're of European descent, right? Because you're likely to have some variations. But again, that was very, very interesting. My question is too, if you're in the banner system and the test results are in, as you order a drug, it will go through the logic to say proceed or caution, too high, too low, consider others. But how do other physicians out in other networks, let's say Copa or Valleywise or Southwest Network, if their psychiatrists want to see the genetic tests, I mean, they get that pamphlet that kind of gives them the overlay of watch out for these drugs and here's why. But is there a service or somehow that they can bounce off particular prescriptions against someone's genetic results?
This is a problem, and this is especially true because in general, genetic test results, most of which are not pharmacogenetic, they may be genetic tests for risk for cancer, genetic tests for risk of other diseases or whatever. Our government has made them, and appropriately so, highly confidential. And so in general, healthcare systems are very reluctant to put genetic test results up on what we call the interchange, in which hospitals share common lab results for patients. So you're exactly right. The only way, at Banner Health, if the test has been ordered from within Banner Health and therefore automatically came back and was inserted into our medical record, then anyone in Banner Health across the United States, whether it be an outpatient clinic or an inpatient, can be affected by those if they order a drug. But if a person gets tested outside of Banner Health, those aren't going to be inside any hospital system's medical record, except perhaps the medical record system of that particular hospital or clinic. And they are not easily shared. And we encourage all of our patients, we give them written instructions, even when we test them as inpatients, on how to download their results. And we encourage them to share them with their physician and to take a picture with their phone of those first 1 or 2 pages that have the genes and the phenotypes on them. But, we very intensively, I teach pharmacology at Mayo and I teach it at the University of Arizona College of Medicine. And we really beat this into the medical students. But most physicians out there practicing never had lectures on pharmacogenetics in medical school. And if you show them, you pull out your cell phone and show them those first 2 pages, they'll look at you and you'll know a whole lot more about it than they will probably. Now, that's not true necessarily for psychiatry. The psychiatrists are probably some of the most educated on this particular topic because so many of their drugs can be affected by it. And they're some of the most active and advanced in promoting it. But that's a very real difficulty, and you want to get hold of your own results and carry them around with you.
So, Francis, you have a question?
I do. First of all, thank you so much, Dr. Curry. This was so interesting. So my son did have one done back in November by GeneSight, which gave his patient genotype and phenotype. Of course, he had like reduced activity, significantly reduced folic acid. But back here on this, it does say he's a rapid metabolizer. It also says, see, this is where I just don't know. I know you say just because it's saying, he's a rapid metabolizer or it's not the best drug for him, if he's doing okay, leave it alone. He's not doing okay. He's never done okay. But he says like he's on clozapine, and he said at the very beginning it made his head feel good. He doesn't want off of it, yet we're really not seeing where it benefits him. And so many drugs are on here that are in the ultra rapid, and at the last page it does say he shouldn't be on it.
Well, I don't know of any pharmacogenetic test that would say a person should not be on clozapine. But as I pointed out before, these test panels are really, the results and everything are written to be interpreted by physicians who understand what the implications are. And of course, I know nothing about your son or his response, and I can't give any advice in that regard. But if I take it, these results were ordered by a psychiatrist, or
they were, and so really what it didn't say don't take it, it said failed medications, failed to work for this patient, previously or currently.
Yeah, well, that would be something the physician entered or the office entered. They couldn't tell that from the test. There had to be information that had to be entered at the time the test was ordered, I would think.
Oh, okay. So they put in clinical history notes, you think?
Yeah, it would depend on the company, what they request when the test is done and everything.
Yeah, we were requesting to see how he benefited from, clozapine. Yeah.
And again, I know Dr. Curry isn't a treating physician of patients on this call, and this is in general trends and what it means. But again, it would be a conversation to have with a psychiatrist with the printout sheet and the clinical picture.
Even if some of you came to see me in clinic with your results, there's no way in the world I would change any of your psychiatric medications. I would leave that entirely up to the psychiatrist. And what we normally do is it's not so important we see the patients as much as we communicate with the physician who sent the patient with us. And they're the ones who get the report, and we help them understand, and they decide what to do with the results then.
Okay, well, thank you. This still was really wonderful.
Yeah. And another question, if a person takes a medication and the medication at whatever dose level they ended up at seems to be working, whether it's giving them more because they don't absorb as much or use as much, or they're actually under therapeutic, but they're rapid, or you know what I mean. But does that stay pretty stable, or does that change over time with the patient's age, physical condition, weight, other things?
It can vary with age. It can vary over the course of the disease. And it can certainly vary with body weight. It varies with drug interactions. So there are many drugs, for example, that will inhibit many of these enzymes. So you may genetically be a normal metabolizer or even a rapid metabolizer. But as an example, if you are prescribed Prozac, which is fluoxetine, that dramatically inhibits P450-2D6, and it makes you a poor metabolizer on the basis of a drug interaction, not based on your genetic code. And so if someone would add a drug like fluoxetine, that could markedly elevate other drugs and produce side effects, et cetera. So there are lots of bases in life for individual variation, and you mentioned some of them. And pharmacogenetics is only one of them. You're exactly right.
Okay, any other questions for Dr.
Lori,
Curry?
I can't find my hand raise signal.
Oh, okay.
Sorry. It's Holly Giesel. Hi, Dr. Curry. So my question is, I think you've made the important point that psychiatrists are well-versed, well-trained in this area, and that you're emphasizing it to all the medical students.
Well,
I
I can't say that all psychiatrists are, but many of the ones I know are. Yes, that's right. But I can't speak for all of them, that's for sure.
I appreciate, yeah, thank you. That's a good clarification. And it's my point. One of the things that I struggle with my criminal clients and dealing with providers is that I have to wait days, weeks to talk to a physician. Are you comfortable with the level of training that psychiatric nurse practitioners are getting? Are they as conversant, as knowledgeable in, in your interactions as the average psychiatrist?
The ones I deal with are not. But I could see how they might be in a visit in a very busy office in which they have a lot of patients that they primarily care for.
Mhm.
I could imagine that some of them are, but I can't provide any, I don't have enough knowledge to make any statement in that regard. I mean, there's so
Okay.
much variation among psychiatrists themselves. I would think it would have to be, on average, they would have to be less informed than psychiatrists with regard to understanding exactly how to interpret it and what the implications are.
Got it. Thank
On the
you.
other hand, if they're in an office where these test results are commonly sought, that is, they order the test regularly, and they work with a psychiatrist who's constantly looking at the test results and adjusting medicines based on them, or choosing medicines based on them, I could understand how they may do really well with them. I don't know what goes on in individual practices.
So it's that daily mentoring, daily experience. Yeah. Thanks so
Yeah.
much.
Do you think long-term that AI can help with, especially maybe not with the individual, but they'll start understanding the interactions between some of the different um, polymorphic genes and the drugs?
Well, if someday perhaps. AI today, of course, mainly just regurgitates what's already been entered into the knowledge base. It doesn't discover or have any insight or hypothesis generating ability. But real quickly, as all of you probably know, it would be wonderful if mental illnesses were due to a single gene. If there was a single gene that's responsible for schizophrenia or bipolar disorder or depression, but we know that that's not the case. And it's probably genetic variation among 5, 10, 15, 20 genes, or maybe a previous viral infection, or who knows what it is. And if that's the case, and we give AI or computer programs the entire genetic code of a person and say, these 10,000 people have schizophrenia, these 10,000 people don't. Do you see some combination of genes among these, millions of different potential combinations that is much more common in the schizophrenic population? Then AI may be able to do something like that. And we've been doing things like that for many years in medicine. And every time someone makes a discovery and publishes a paper on it, usually someone else is unable to replicate that. And so that has not been very successful to date, although perhaps someday it may be. That's just my general observation.
Okay, we had some comments. First, a question about, does insurance cover genetic testing?
Some insurance companies, some insurance policies, including Medicare or disability, cover genetic testing for specific drugs. So, for example, if you're on amitriptyline, it says, yes, we will pay to test for polymorphisms among these 2 genes. Okay. There's a law in Arizona passed by the legislature that insurance companies are required to pay for genetic testing that a physician feels may be relevant. But most insurance companies to date are simply ignoring that rule and knowing that most people are not going to sue them for the cost of a genetic test. But there are many companies who will pay for selective genetic testing, mainly based on what Medicare will pay for. And there are a few drugs they will do that for.
That's encouraging. Another, I know we saw the release about the new schizophrenic drug that was just released, Cobenfy or Cobenfy. But the thing that worried me when I looked at it, it seems like the study groups and the people they studied, they were really small trials. So, I'm a little,
Yeah, I've not
yeah.
read the studies in detail, but I've looked at the results, and the outcomes were not very long. That is, the patients weren't on them for a long period of time. And as typical for new drugs in phase 3, there weren't necessarily huge numbers of patients. And if the differences between groups are large enough, and you don't need large numbers of patients, then, especially if it's something that's really a new drug working by a new mechanism, which this drug is, by stimulating what we say are muscarinic receptors in the brain, then the FDA will go ahead and say, well, you've proved your case. We're going to go ahead and allow you to make this drug. But there are going to be a whole lot of more trials coming out with that drug, including for bipolar disease, I would think, and possibly even an Alzheimer's disease.
That's great. Anyone else have a question for Dr. Curry? Should be respectful of his time. Okay, well, Dr. Curry, I'll stop the recording. Oh, Rachel has a question. So, Rachel?
Hey there, I do have a question. You mentioned that there's a law that says that if a physician feels that a genetic test is important for a patient, that Arizona law says it should be covered. There's a new company called Myogenes that has some interesting genetic tests that predict the likelihood of developing clozapine-induced neutropenia. It also tests for the Duffy null gene for benign ethnic neutropenia and some other interesting things that are kind of unique to clozapine metabolism. It's a test they're using. They've been using it in the UK. It's now available here. Is that something that we should be pushing our insurance plans to cover?
I don't know enough about that to answer. I don't know how good the test is at predicting. I've not read studies on using that test to guide clozapine therapy. There is if you look on the internet, you can go to, let me see if I can find the name here. I got to stop sharing my screen here. So
Okay.
there we go. There's what's called the Clinical Pharmacogenetics Implementation Consortium. And its website is called CPIC, CPICPGX for pharmacogenetic.org. So it's CPICPGX.org. Or if you just Google CPIC drug gene pairs, CPIC drug gene pairs. This is a consortium of researchers, and they're funded by the National Institute of Health. And you can click on their drug gene pairs. And they go through all the different drugs for which there are pharmacogenetic genes for which testing may be invaluable. It's been proved to be of no value, for which there's high value or whatever. And you could look up clozapine there and see if they've done an evaluation on that. And the only reason I mention that is that's sort of one of the standard sites that an insurance company would go to see whether there's really good evidence supporting paying
Okay.
for testing like that.
No, that's very helpful. Thank you.
Sure.
Okay. And with that, what we'll do is we'll stop the recording. At this point, what we typically do is we switch over